Our next panel focuses on reducing the mental health crisis and leading cause of death together. Common mental health disorders are linked to a higher risk of heart attack and stroke, and heart conditions increase the chances of mental health issues. This session will address the mental and cardiovascular health connection and how we could simultaneously improve mental and cardiometabolic health. We will begin with a conversation between Dr. Ileana Pina, Professor and Quality Officer in the Heart and Vascular Service Line at Thomas Jefferson University and a National Forum Board member, and Captain Christopher Jones, Director of the Center for Substance Abuse Prevention at the Substance Abuse and Mental Health Services Administration. I'll follow Drs. Pina and Jones with an interview with the Mayor of West Sacramento, California, Martha Guerrero. Now, Drs. Pina and Jones.
Hello, everyone. In this session, we will examine the connection between mental health and cardiovascular health, which is thought to be actually by going back and forth between the two. And it is really widely acknowledged that common mental health disorders are really very heightenedly tightened to the risk of heart attacks and strokes. I see it in the patients all the time. And that experts in cardiac psychiatry believe that this is a bidirectional suggestion or a bidirectional association. Poor mental health, which again, I see this every day, can exacerbate heart health issues. And on the other hand, cardiovascular conditions can elevate the likelihood of mental health. So, Dr. Jones, welcome to be here with me. As an expert, you have extensive experience in the public health world and substance abuse and prevention, which will provide us very valuable perspectives for our conversation. Can you tell me a little bit of what you do in your service?
Sure, and thanks so much for the opportunity to be here today. Currently, I serve as the director of the Center for Substance Abuse Prevention at SAMHSA, which really focuses on the upstream aspects of substance use, mental health promotion, really thinking about how do we look at these factors that play out early in life that contribute to risk for substance use or mental health, and ultimately even risk for chronic diseases like cardiovascular disease later in life, and try to work with communities, policymakers, researchers, coalitions to take a wide perspective of prevention and think about what can we do at the individual level, at the family and relationship level, at the community level, at the societal level to implement prevention strategies that can have these broad payoffs for public health. Prior to my role at SAMHSA, I was the director of the Injury Center at CDC, which also focused on many of these similar issues in the connection between those early life experiences and later health risk behaviors and chronic disease as well.
So how early in life? You said early in life. Do you think this starts in the teenage years where post-puberty? When does this start?
I actually think it starts even further upstream. So if we look at the research around exposure to trauma or adverse childhood experiences, which started in the chronic disease area at CDC, basically asking adults, what was your early life like that might be a predictor to your current health state? And what you find is that people who experience things like physical or emotional abuse or neglect, sexual abuse, were raised in a household that had mental health or substance use challenges, divorce, incarceration of a parent, really things that can introduce instability or insecurity in a child's life early on is a strong predictor for future health risk behaviors. And there's sort of a logical connection between those early years in life where you're making important neural connections around emotional regulation, how you respond to stress, being able to evaluate benefits and risks, that we know those early years are so important in the developmental process that you can see when people have experienced trauma early on, they tend to have a sort of an overriding stress or toxic stress response, which then can lead to early adoption of health risk behaviors, things like smoking, alcohol use, which then accumulate over time and then certainly have implications for chronic disease like heart disease or diabetes. And as you mentioned at the top, this sort of bidirectional or multidirectional relationship between substance use, health risk behaviors, mental health, and chronic disease. So from my perspective, we have to start long before middle or high school, which is when some of the risk behaviors might start to emerge, but we really miss prevention opportunities if we don't start earlier in life.
And so I like your points. As a cardiologist, I see people who already have cardiovascular disease. And we do take a history, and the history for the family is usually anyone in your family have heart disease? Did anybody die suddenly? Is there a high blood pressure history in your family? And we ask all these things. But as you're pointing out, the earlier life experiences, whatever they happen to be, will also, I think, reduce the healthcare importance to that individual. They will not pay as much attention to symptoms. They may not get their blood pressure ever checked. Or hear from other people, your blood pressure is fine, don't worry about it. And so their cues are coming from a lot of places. And we do talk a lot about health literacy. So, and I think that health literacy is formed in the home, usually from your parents, who may in fact go get their flu shots and they get their, their blood tests and they get their annual physicals, to the children who never see that again. If the parents are doing it, but they're not getting it done, there's a bad link here. And then take the opposite. I just gave a talk recently that I said, I always give bad news, or I often give bad news. And my bad news are you have heart failure. And that's a pretty bad thing to hear. And we know that there's a link between heart failure and depression, that about more than a third of heart failure patients are actually clinically depressed. But one of our barriers is that they give us 20 minutes to see a follow-up. How the heck can you ever get that history in a 20-minute follow-up? And I'm not a psychiatrist. I'm not in the mental health field. How can I get them to the right person to talk to them and get maybe a deeper history of that link that you were talking about really early on? And I think those are barriers within our health system. And my third concern is that some of the drugs that I use for the heart failure, for example, may interact with an antidepressant or an anti-anxiety. And we've written papers about this, and I can refer the audience to a paper in the Journal of the American College of Cardiology, where I'm the first author, where we did talk about this, about the medication interactions that people, and you're a pharmacist, that people need to be careful about. How do you assess that between the heart drugs and the medications that may be given for all kinds of mental health disorders?
Yeah, I mean, it certainly is a complicated situation, and I think it is sort of emblematic of a very fragmented healthcare system, right? We have mental health treatment, we have substance use treatment, we have physical health care, and oftentimes those are not integrated. That people are sort of piecemealing their care together, and so care teams don't even have the opportunity to strategize about what are the options, right? What are the therapeutic options that might be able to treat an underlying heart failure or cardiovascular condition that might be a better option for somebody who is on, an antipsychotic or an antidepressant or some multiple medications for mental health conditions, in addition to other risk behaviors that they might be engaging in. So I think it does underscore the need for trying to integrate physical healthcare with behavioral health. That's certainly an area at SAMHSA that we have been particularly interested in and trying to provide funding and work with CMS and others across federal health agencies to enable that. In some cases, that's physical co-location of services. In others, it's thinking about systems and IT systems. How can they work together? So you as a cardiologist, if you have high prevalence of depression among your patients, you've got that connection. Maybe they're not right in your office, but you know who you can refer out to get those additional psychological, psychosocial services, or a consult for medications. What is the right mix? Or even if things do have significant potential adverse reactions, we can monitor for that, right? We can have a care plan in place for the patient to meet their therapeutic goals, both on the heart health side, but also on the mental health or substance use side.
Yeah, I'll give you a couple of examples. When I was at the Hahnemann Hospital here in Philadelphia in the late 80s, I actually had interns from psychology who were rotating with us, both for the exercise team, which we'll talk about in a few minutes, and for the heart failure team. And they were highly, highly invaluable. Because they interacted with the families too, because a lot of this is a family affair, that it's not just a patient, but whoever is around them that can either contribute to the mental health issues or alleviate them, one or the other. And so we had that there. And then in Case Western in Cleveland, I actually had one of these individuals in my office clinic with a room of her own. She was also dynamite and fantastic. And when we identified some issues with the patient, we would send them to her. And it just really, really worked well. Here at Jefferson, we don't have a mental health person embedded into the team, but you're right. We have the Department of Psychiatry, the Department of Psychology. But I'll give you another perfect example. I have a gentleman who really sick. I mean, he came in shocky with heart failure, had sudden death. And he was a bear to deal with. He was angry. He was upset. A man who had been very strong and, he worked for a security station. I'm going to get sick like this? Impossible. And he was really lashing out at everybody and preventing us from evaluating him for advanced therapies, in the future, once we could get his heart failure controlled. And we did send him to one of our local psychologists or psychiatrists, I don't remember which, but he got put on an anti-anxiety drug. And we had one of our pharmacists take a look at the combination to see if there was any interaction. And he is like a changed man. He's listening to us. He's following what we've asked him to do. And now we're hoping we can transplant him. So we've come a long way. It's taken us almost a year to get here. But there's a perfect example. And more recently, I now have pharmacists. I happen to really love the role of pharmacists in our clinics. And I now have 2 or 3 pharmacists, young women, who are rotating with us, but they're coming back to our post-discharge clinic. And I can tell you already they're making an impact, because then I'll leave the room and I let them talk directly to the patient. And they're looking for those drug-drug interactions. And they'll say to me, you can't start this, you can't start that. So I really urge anyone who's listening to this to think within, as you were saying, within your own system of care. Who do you have that you can go to for this? So let me ask you, if you had to give an antidepressive drug, let's say, because I see more depression than anything else, is there a type of drug that you think would have less interaction with our medications?
I mean, I think it really just depends. I mean, there are, SSRIs, SNRI, SSRI combination products, are often the go-to for depression. And even though they have similar mechanisms of action, those individual drugs within that class have different effects on metabolism for certain medications. And so there really is a need to sort of not take a one-size-fits-all approach. You may know sort of generally the therapeutic class, but it does come down to what particular combination of medications somebody might be getting. Do they also have, co-occurring type 2 diabetes, and what medications that are getting for that? If you're dealing with medications that are certainly impacting heart function, regulating rhythms, those types of things, we obviously want to be very careful about anything that might either decrease or increase the therapeutic amount of those drugs. So
like
again,
QT interval, you mean like QT interval prolongation?
Right. So if you get a super therapeutic dose because of slowed metabolism due to an antidepressant, that could have substantial consequences. But similarly, if metabolism of cardiovascular meds get sped up because of psychiatric medications, and you're not getting enough of a therapeutic dose. So it really can work both ways. So I would underscore your experience in your current clinic of having those pharmacists on hand. I mean, even if they're not rotating on your service in the system, there are pharmacists there that can, be brought in to consult on those issues. And I would just also underscore what you mentioned a moment ago about engaging with the family and thinking about even outside of medications, what are other therapeutic modalities that can be beneficial, and looking at things like exercise, just even family engagement, connection. People, when they're very sick, they're in and out of the hospital or the doctor's office. It's really easy to feel isolated, and that you can't engage in the things that you used to enjoy engaging in. And so, really taking that as an important part of the therapeutic approach to address those issues is particularly important as well. And I think allows us to think holistically from the patient's perspective. And I loved your example of the individual who came in who was sort of hyped up and, frustrated and angry and got on an antidepressant. I mean, in some cases, past exposure to trauma or ACEs may present in that way, or you may have some barriers to engaging optimally in a therapeutic plan with a patient. And you have to take trauma-informed approaches to care. And there is a whole movement to really think about, not just in mental health or substance use, but in healthcare generally, how do we really take into account prior trauma as part of the therapeutic approach? There are psychosocial treatments like trauma-focused cognitive behavioral therapy that can be really helpful for individuals to address their past trauma, but that trauma may also be getting in the way of you engaging in optimally improving their heart health as well. So it really is looking at the person is in a whole, from psychosocial, substance use, and medical, to address, all of the issues that may be contributing to the challenges they're facing.
So for my colleagues who perhaps are not, or they're running, we're busy, we get told you have to see more and more patients to meet your RVUs, et cetera. Do we have any short questionnaire, like we will be using very soon the Kansas City cardiomyopathy questionnaire for health status? But it touches on quality of life, because one of the questions has to do with quality of life, but it really doesn't touch on the mental health. Is there a questionnaire, something easy that we could give the patients when they're sitting there in the waiting room complaining that we're running late, that they could fill out that would, if you look at it, you say, I got to pay attention to this because there's something going on. Is there such a thing?
Yeah, so there are sort of short screeners that can be used for depression or anxiety. There are like 1 or 2 question screeners that can be used to identify potential substance use challenges that could be integrated into patient intake. When they're filling out, what medications do you take? Has anything changed in your history? A series of, 5 to 9 questions on some of those. Some are shorter than others. So there are resources that are available that could at least flag for the clinician to just maybe have the conversation. I think what we see generally from the research is that it's relatively rare for clinicians to even have the discussion or raise the question around mental health challenges or substance use. And often that's because there are, many competing priorities. You have a limited amount of time, but also some of it is that clinicians that are not trained in those areas don't feel comfortable engaging in those discussions because they're not sure what to do with the patient. And again, I think this, gets to how do we think about mental health and substance use training and health professional programs? How do we create within electronic health records screeners, but also prompts for clinicians? And then thinking about those connections within the system, right? If somebody comes up positive, it's not that you've got to address all of that right then and there, but that you have a system in place in which to then refer them or connect them to care that can address those particular issues.
What troubles me is that if we don't identify some of these issues, the patient's not taking the medicines. And I hear it immediately when I see that they say, I don't need refills. I don't need refills probably means that they still have drug because they haven't been taking it. I think COVID was a wonderful example. During COVID, I don't know if you're aware of this, the heart failure hospitalizations dropped. And I mean dropped like a rocket. And we were all saying, oh my God, they're probably at home getting sicker. Well, they weren't. When they would come in, they would come in at the same sickness level as they did before. And what I think was happening is that they were taking their medicines for a change. And the medicines do work with the heart disease. They do work. And they weren't eating out, junk food every day. So their diet was probably healthier. And thirdly, they probably had someone in their immediate caregiver team, their parent, their brother, their sister, even a friend who was hovering over them so they wouldn't come into the hospital, because everybody was terrified to come to the hospital and catch COVID from somebody else. So we saw this phenomena, and as the pandemic subsided, the hospitalizations started going up again. And we even have data of pressures that were better. Even when you weren't doing anything, they were better. To me, it means they were taking their meds. I'm going to hunt around to see if I find any of those. And you may want to provide to our national quality group here any suggestions of these questionnaires. We're trying to do the same thing for things like sleep apnea. There's another one. The sleep apnea can affect the mental health as well because patients aren't sleeping. So even identifying that, we have some questionnaires to figure that out. What do you think we can do? I mean, you are also in service of your country. I work for the FDA as well. What can we do nationally to sort of say to the public, we have a crisis. This is really bidirectional. If we don't attack this, the cardiovascular disease is not going to get better. Our medications are getting more complicated, and the patient's diseases themselves are getting more complex. How can we do this?
Yeah, I mean, I think that we are really at such a critical point in time. I mean, if you look at mental health indicators in the US, those have been going in the wrong direction, in particular among young people over the last decade. Data from CDC's Youth Risk Behavior Survey shows 42% of high school students felt persistently sad or hopeless. 20% thought about suicide in the past year, and 1 in 10 attempted suicide. And you see 110,000 overdose deaths in the past year. We see higher rates of substance use among people who have mental health conditions, and then this connection to chronic disease as well. And I think it's really a time for us within the healthcare sphere, within the government sphere, and within policymakers to come together, first to underscore that these are not disconnected issues, that they are reflective of broader trends that are happening and playing out in communities, and that there really is a role for all of us to play in addressing these issues, whether you're a family member, a caregiver, a healthcare provider, providing social services, working in other sectors, education, criminal justice. We need to be working together, talking together about what are those shared risk and protective factors, starting early in life, thinking about how are we supporting families and young kids? How are we creating opportunities in communities for jobs, for education, to lift people out of poverty? How do we think about social determinants, housing, transportation? These are all very much connected to chronic disease, but also to mental health and substance use. So I think we use the concern about these issues and the just tremendous impact to health and economic costs to say what we've been doing hasn't been working. We need to look at this in a more holistic way, working together across sectors, that there are no simple solutions. These are complex issues, but if we're all pulling our various levers together, we really do have an opportunity to make an impact. And we can't start when the problems are diagnosed, right? That is part of it, but we've got to start long before we get to that point. And we can get ahead of these challenges. We did an analysis a couple of years ago at CDC that was basically asking the question, if we could prevent ACEs, what would the potential public health impacts be? And we saw like a 33% drop in smoking, 25% drop in alcohol use, but also significant declines in cardiovascular disease, respiratory disease, cancer, other leading causes of death. So there really is an opportunity to get ahead of the challenges that we're facing, while also addressing the challenges that exist in communities. But it will take all of us working together.
Yeah, if you kind of turn this around, you can say that healthy living starting early will really prevent a lot of this because the patients may feel better. And I can tell you from the cardiovascular side of things, people would only take their blood pressure medicines. We could reduce what I do in heart failure by 50%. I mean, it's not trivial because with hypertension, especially in some of these underrepresented minority communities, what we see is stroke. We see stroke more than heart attacks. We see strokes and, of course, heart failure. And when the heart is failing, the kidneys are gone. So many of these patients have to go into dialysis. And that can be a very depressing point in their life when they have to sit in a chair for 4 hours, 3 times a week to take over their kidney function. So I try to make sure that I explain to the patients what things you're going to be preventing by just simply taking your medications and lowering the blood pressure. And at this point, it doesn't even matter which drug, as long as that blood pressure actually does come down. So to me, there's a direct link. One other interesting link, and our subsequent panel here will be talking about physical activity in the community. So we did a 2,231 person trial, an NIH trial of exercise in heart failure. And we randomized the patients either to, stay active, stay moving, etc., or coming actually to a cardiac rehab program and doing the exercise. The adherence was terrible. We didn't meet our primary endpoint as we wanted it because we lost adherence even very early, and this was free to them. We had set up satellites so they wouldn't have to drive downtown. Most patients hate driving downtown and having to park. That's always a big barrier. So we made it easier for them to have centers near home. And then we gave them a piece of equipment in the home to use and to keep. We had a bicycle or a treadmill. And even there, the adherence was not great at all. Not great. It was pretty bad. And it may have ended up, giving us a lesser of a result in the trial, which we were hoping that we would have. However, we did do the Beck depression inventory on everybody. And we found that there was quite a high percentage of patients whose scores were over 14. And then at the end of the study, now remember we have a control group and we have an intervention group. And regardless, as long as that Beck depression inventory was high and they weren't exercising, their outcomes were worse. So, if they were exercising with a higher Beck or a lower Beck, they did better. So to us, there's the direct link between physical activity. In a case of a group that had an ejection fraction of 25, I mean, these were real, low ejection fraction patients in a very large number, and it worked, so we have data on that, and we have papers on that because we felt that was just a beautiful link between the two. But I fear that my colleagues, maybe who are not doing heart failure, who are doing more general cardiology or even interventions, being told that you need a new heart is pretty scary. Our transplant group does have a social worker that deals a lot with the mental health issues of the patients. But the average cardiologist doesn't have that unless you set it up that way. And I think that's that recognition by our bigger systems of care about what you just stated, the need to focus and examine what else is going on in these patients in their lives that has brought them here and may allow them not to do well. And so I am very worried about these people. And part of what that talk that I gave was, what can we trust that the patients believe us? Because in the model of change, if they don't believe you, they're not going to do anything. So how can we try to prevent anxiety, for me as a cardiologist, for patients who I haven't seen, the general population that we're trying to prevent. And now we have all these cardiometabolic diseases like diabetes. I don't have to tell you, you probably see a lot of that in your area. How can we go, like you were saying, up beyond earlier? How can we do that?
Yeah, I mean, so this is like the sweet spot for prevention is really thinking about how are we helping to ensure a strong start for families and kids, and how are we looking at this from a life course perspective, from a developmental perspective. So again, there are very early programs like home visitation programs, nurse family partnership as an example, that are helping expecting parents sort of get ready. And they do, follow up with kids through the age of 2 years old or so, where they're looking at what social services, what medical services. So again, they're sort of helping to have that strong start. And then as you're thinking about like, even before kids start school, do they have opportunities for learning? How are we supporting families? How are we looking at, making ends meet within homes? What are those stressors that are contributing, right? Whether it's stressors that are contributing to health risk behaviors for parents or that are influencing the developmental trajectories of those kids, there is an opportunity to get ahead of it. And then as kids get into school, thinking about how do we support them to develop healthy relationships, to help with problem solving, conflict resolution. And I think to me, healthy eating, exercise, having those connections, healthy connections to parents, to other non-parental adult role models, and to their peers, while maybe it's not intuitive that this somehow improves their cardiovascular health late in life, there is science there that does show that if we can do those things and we can prevent initiation of risk behaviors like smoking or alcohol use or substance use, that if we can instill sort of healthy relationships, resilience, kids have less risk for mental health conditions later on in adolescence, young adulthood, later on in life. And you could see how both mental health and substance use could have these cascading effects to chronic disease later on. And so I think it's helping to make those connections more tangible and real for people of how do you get from what happens early in life to these later stage consequences, which you're seeing in your clinic. But that there is science that lays out policies, programs, practices that can be put in place in communities to address those issues, to really help improve the overall health of communities. And I think we haven't made commensurate investments in those types of activities as we do to sort of the healthcare system and treating the problems once they have developed. So I think we have to find some better balance in investing in those upstream prevention interventions, which can have these long-term payoffs and save dollars later on down the road.
It would save us a lot of money down the road if we were able to attack these issues early. I want to refocus just on women and pregnancy. It is a message that there are some trials ongoing now about getting the message to women who are planning to get pregnant or already pregnant, that what happens to them during pregnancy as far as cardiovascular, like hypertension or diabetes of pregnancy, that it's going to impact them earlier in life than, say, their grandmother who never had those. They're going to be impacted perhaps in their 40s and their early 50s, not in their 60s and 70s when you see it more often. So, that the health and the health of the fetus is equally important to your health, and taking your medications and taking care of you. Another big point in women is obesity. In the African American population, which is also associated with all these other disorders. But if you go back, and that's a question that I asked 2 or 3 of my patients this week, when did you start having, because rather than using the word obesity, when did you start having weight issues? And they understand that when I say weight issues, because it's not judgmental. And you'll hear that it starts really early, back in their teenage years, where eating was no longer healthy. So getting to that early group is so important. I think it involves the schools, and of course, it involves the parents in the home, teaching the children. When you see families who are obese, usually everybody's obese in the family. So I always say that women can control the food intake in the family, and they have it in their hands to improve that. So with the American Heart Association, we focus a lot on Go Red for Women and what can we do as women to improve our health for the lifetime. Not just at one point. By the time I see them, they're way gone, and much tougher to identify. Do you have a
Yeah,
lot of women in your practices there?
At SAMHSA, we obviously are dealing with a variety of communities. One of the areas that we have tried to focus on is equity and disparities that exist. And I think you would see strong correlation with communities that are disproportionately impacted by substance use or mental health challenges that also have chronic challenges. And I think to your point on sort of nutrition, that there is sort of individual agency there, but I would also say that there are structural factors that contribute, right? So if you live in a community that has been a substantial amount of disinvestment and all you have is fast food restaurants and you don't have access to affordable, healthy options, it's not surprising that the behaviors would be you eat what you can afford. And I think that really looking at the sort of economic structural factors is another key upstream part of this. I mean, same with exercise, right? If you don't feel safe going out in your community or your community doesn't have places to go exercise, it becomes a challenge. If you fear being shot walking down the street, regardless of what age you are, you are likely not to engage in that behavior. Or if you don't have green spaces or basketball courts or soccer fields in your community or sidewalks in your community, that can have really important impacts on mental health, on risk for substance use, on chronic disease. So I think in addition to the individual, we have to look at those structural factors as well.
You may not be surprised that where I have been, both in New York and in Philadelphia, I have some women patients in particular who, when I tell them I need you to walk 45 minutes a day, I don't care where you do it, they'll say to me, I really don't have, like you just said, I don't have a place. And so what I've done with them is if I find out how they live, in other words, do they have a one-bedroom apartment or do they have a little house, do they have stairs, even if they have 3 or 4 steps, going up and down those steps repeatedly, or walking around inside their house. And in New York, where these big buildings are there, these concrete jungles, there's hallways. So if they feel safe, at least in that hallway, you can use the hallway. So we need to become very inventive in what we do. But I think it's an issue for all of us. And hopefully in the next segment, we're going to hear more about how can a community improve these things. You talked about what I call food deserts, where you can actually map out where the food deserts are. There's more hypertension, there's more diabetes, simply because there is no access. So we're going to be hearing about physical activity and all these social connections in the community that can maybe prevent anxiety and stress and depression and make people healthier in their hearts. So I'm going to close now, and I want to thank you, Captain, for giving us your incredible experience. You've been doing this for a while. It's been really an honor to sit here with you. And for our audience, I think we aim not only to understand this very intricate connection between heart health and mental health, and it didn't just start the day I saw the patient, it started way back, and to try to identify tangible solutions, which is going to take a village. This isn't something I can't do by myself. I have to involve my system and giving them that sense that, hey, this is important. We can't keep ignoring it. And maybe making this a healthier and a more equitable future for all. I also think that sometimes social media is very much in the way of disinformation instead of good information, which is what it was, I think, originally meant to be. So, Dr. Jones, thank you again for being with me, and hopefully we'll nab you again for another National Quorum meeting. Have a great
Great.
day, everyone. Thanks for being
Thank
here.
you so much. Thank you.